So please can you play that recording of Dr. Vandita Singh? I think Dr. Vandita Singh is a assistant professor, Department of Pathology at AIMS, All India Institute of Medical College, Medical Sciences in Raipur, India. And Dr. Vandita Singh, please play her recording.
Very good afternoon. I'm Dr. Vandita Singh, Associate Professor Pathology, All India Institute of Medical Sciences, Raipur. I shall be presenting a case of rhinosporidiosis diagnosed on nasal discharge cytology. Co-author of the study is Dr. Ashish Saraf, and I acknowledge Department of ENT for providing clinical details of this patient. A 16-year-old woman presented with a periorbital compressible swelling, which on pressing elicited a nasal discharge in the ipsilateral nostril. On examination of the nasal cavity, a friable vascular polypoidal mass was noted with dot-like structures on its surface resembling a strawberry. The nasal discharge cytology revealed an acute inflammatory background within which were scattered bluish sac-like structures. On higher power, the sac-like structures had vaguely discernible wall around 5 micron in size. The size of the sac-like structure was around 500 microns, and within which were small dot-like or circular structures about 6 to 7 micron in size. Based on this morphology, we made a diagnosis of rhinosporidiosis. Also present in the smear was acute inflammatory background and epithelial cell clusters. So we made a diagnosis in the right clinical context, but cytomorphologically, the close differentials for which this can be mistaken are coccidioides, which is a dimorphic fungus. The sporangia of coccidioides, unlike rhinosporidium, is smaller, only 60 microns in size. Its clinical features and morphology can easily distinguish it from rhinosporidiosis. In India, it is extremely rare. Only 8 cases have been described, which have all been imported. And mucicamine stain is negative in the sporangia of this lesion. The other close morphological differential can be myospherulosis, which is an iatrogenic mass created due to emulsification of RBC membrane along with paraffin-like or petroleum-containing products post-surgery or trauma. Because this is just RBCs, therefore on higher power examination you can make out the RBCs and its structure. Because it is not a fungus, it is pars and GMS negative. Human protothecosis, which is a rare disease involving the skin, olecranon, or rarely the systemic system, caused by algae. On KOH mount shows up sporangia which are very small, 3 to 10 micron in size, and have a soccer ball appearance on KOH, which needs to be treated with antifungals. An extremely rare disease, adiaspiromycosis, is a rare fungal infection of the lung caused by inhalation of spores. Only 40 cases have been described for so far. This disease generally just involves the lungs, giving rise to reticulonodular shadows. After the cytology diagnosis was made, a CT scan was done to look at the extent of the lesion because rhinosporidium needs to be excised so that it does not recur. This disease was primarily in the periorbital tissues involving the nasolacrimal apparatus, extending via the same into the nasal cavity. Endoscopic biopsy revealed multiple sporangia studding the subepithelium. On higher power, the sporangia gave rise to a Swiss cheese appearance to the tissue with hyperplasia of the overlying epithelium. At places, the sporangial walls had ruptured, excluding the endospores out, giving rise to a foreign body joint cell reaction. So although in our case the disease was primarily nasopharyngeal, giving rise to multiple recurrences, this disease can spread to the skin around the nasal mucosa or even present as cutaneous disseminated disease. In the cytologic diagnosis of rhinosporidiosis, most of the articles are from Southeast Asia, where most cases have been described in males between 11 to 30 years of age who get infected because of contact with the organism in stagnant water. There has been leukocytosis and eosinophilia associated, which described by several authors, not seen in our case. And the most common extranasal site described has been the periorbital tissue. Sensitivity and specificity of cytologic diagnosis of rhinosporidiosis is almost 100%. And therefore, this is an important diagnosis to make in cytology given the right clinical context. So, Rhinosporidiosis is a chronic granulomatous infection due to Rhinosporidium seaberry, an organism intermediate between Protista and fungi. It is endemic to certain zones in the world, predominantly affecting as mass lesions, affecting the nasopharynx and oropharynx, but also disseminated cutaneous disease or elsewhere. Cytology is a rapid low-cost technique to make this diagnosis with high sensitivity and specificity. In order to triage these patients for surgery, which is the only sure shot management for these cases. There are cytomorphological differentials which can be mistaken for Rhinosporidium but can be easily excluded by clinical features and cytomorphology. These are my references. Thank you.
For giving a detailed description and presentation of rhinosporidiosis, which is seen in many parts of India, especially South India, in Sri Lanka, and as she said, the Southeast Asia. And Dr. Vandita Singh has described the clinical features, the diagnosis, the differential diagnosis, and the other features of rhinosporidiosis. We see many cases of rhinosporidiosis on histopathology, but maybe in cytology we do not see that many. So I think it's a good eye-opener that everybody should be aware of this disease, rhinosporidiosis. Thank you, Dr. Vandita Singh. Any questions for Dr. Vandita Singh?